それでは次に、開会講演をジョンズ・ホプキンス大学、ブルームバーグ、スクール・オブ・パブリック・ヘルス大学院長、マイケル・クラッグ先生にお願いいたします。クラッグ先生は、現在 WHS の母体である M8 アライアンス幹部委員会、エグゼクティブコミティの委員のお一人で、M8 設立当初から WHS に多大な貢献をされてきました。第4回世界医学サミットベルリン2012の会頭を務められました。クラッグ先生、よろしくお願いいたします。
Good morning, everybody. It's a great honor and privilege to be here today at Kyoto University and to see old colleagues and new colleagues and to see so many friends and colleagues from the M8. So, I really thank Shunichi for this opportunity and for the members of the organizing committee. So as I was thinking about what to talk about, I was struck that every time Shunichi and I speak, we talk about the issues of aging. And I thought that I might give a talk that really stems from my background as somebody who a major part of my career was doing clinical medicine, but also doing public health. So a little bit in terms of reflections on the aging of society. And I just put this picture in. This is a picture of Johns Hopkins Bloomberg School of Public Health. You're all invited to come and visit. So this is the talk that I prepared. First, how old are we as a globe? And in terms of people and populations. And we've talked about life expectancy has increased. Why is that so? What are the population dynamics that underlie that? And then, are older people becoming sicker? Are we accumulating more and more old people who are sicker and sicker? Or, as some have suggested, are people more healthier now than they were in the past at older ages? And then what do we know about achieving healthy aging, an issue that Shunichi brought up? So this slide shows the population distribution by age of Japan over a 70 or 80-year period. And it shows what everybody in this room knows. So this blue line here is the total population with the numbers there. And you can see that population has been increasing since 1945 at first a higher rate and then has leveled off. And as you probably know, and it was mentioned earlier, the birth rate is declining, and in fact, we are now at the maximum, the projections are at the maximum population in Japan, and the population is going to decrease. The other lines show the percent of the population for different age groups. And I want to draw your attention to the yellow line here, which is 0 to 14 years of age. So you can see back around 1935, that was almost 40% of the population, and we've seen a steady decline. So now we have about 12% of the population is in that age group. But look at what's happened to 65-year-old plus. So Japan has led the world in terms of aging as a percent of the population. So now we're at almost a quarter of the population being 65 years or older. What about the rest of the world? Well, this is a population pyramid, and you're probably familiar with these kinds of graphs, but basically it's a number of people. This would be for males on the right-hand side, females here, by age group. And this is for the entire world. And so the inner gray boxes there, they reflect what the population of the world looked like in 1950. And it was a classic population pyramid, right, with the largest group being 0 to 5-year-olds, and then successively smaller throughout life. So you have a pyramid with a broad base and a relatively small fraction of the population at older age groups. These bars here represent 2010. And you can see the population has grown, right? But we also see that the fraction of the population from 0 to 4 years old is the same up to about 25 years old. And what's going to happen as the momentum of the population continues is that it's projected by 2050 that instead of a pyramid, we will have a monolith, right? That the distribution of by age of the population will be the same up through middle age. So what we're seeing in Japan, we're seeing around the world, although Japan is leading the way. Now, what drives this aging of the population? And we've already heard some suggestions about this, but the number one thing, of course, is life expectancy. So this slide shows life expectancy at birth by region of the world over a 60-year period. And so if you look here at Western Europe, there's been a steady increase. In fact, almost every segment of the globe has seen an increase in life expectancy, except for Southern and Central Africa. And that reflects two things. One is the HIV epidemic in Southern Africa and the scourge of conflict and HIV in Central Africa. But essentially, we're seeing this pattern of people living longer, population life expectancy going up throughout the world. And the major driver for that is what's happened with child mortality, under 5 mortality. It's really remarkable. We have a long way to go. There are still many countries where child mortality is too high. But if you look at the world as a whole, it's really remarkable the accomplishments that have happened. So this black line is for the entire world, and you can see that back in 1950 it was estimated that the average was 230 per 1,000 live births. Think about that. A quarter of children died before age 5. And that's gone down now to a level of about 50. It doesn't show well on this map per 1,000. And it's true in all segments of the world. So Africa up here lags behind far too much, but even there we've seen a reduction. And this is Central Asia here, South Central Asia, and you can see that it started at very high levels, but now is almost at the world average. We have much more room to go here. We have great challenges to overcome, but under 5 mortality is the biggest driver of increased longevity because it's the highest mortality in the lifetime until we get to older ages. So this is a good thing. One of the reasons that we're aging is because we've tackled the problem of under 5 mortality and are succeeding. We talked a little bit earlier about the birth rate in Japan. So this is a graph of total fertility by country, and this is an average of 5 years from 2005 and 2010. And you can see there's a huge range from down here about 1 all the way up to over 7. So what does that mean? Well, that means that number of 7.19 means that the average woman during her reproductive years will have 7 live births. And if you're at 1, they'll have 1 live birth. Now, replacement demographers tell us that to maintain a stable population is about 2.1. Right? So if you think it takes 2 people to make a baby, you need to have 2 children, and then allowing for mortality and whatnot, you need a replacement value is about total fertility about 2.1. You can see about half the countries now are below that, half are above that. These tend to be in the global south, and if you look at the policies of countries that are above that level, they tend to be policies that promote family planning, spacing, and limiting of births. And those countries below the red line, like Japan and like the US, we tend to have more pronatal policies. That is, how do we increase population? How do we deal with the issue of, as Japan is, of an aging population when we're having a smaller and smaller fraction of the population, say, below age 50. So it's different, but Japan is right here. And what we see in toto about this is that that the increase in population in the world now is being driven in sub-Saharan Africa, and that we're estimated to reach 10 billion people by the end of this century. Whether the globe has that carrying capacity to be able to accommodate 10 billion people is an open question. So decreasing the number of births is a good thing, but there's, just like physicians in the US, there's a maldistribution geographically of birth rates. Because we're aging, because we're living longer, what we see is a change in the pattern of mortality around the world. So this is data on a number of deaths in millions here, and this is for all countries. And what you see is that the 3 leading causes of death are cardiovascular disease, cancer, and injuries. Some lists have respiratory diseases in the top 3. That's very different from when my school was founded 100 years ago. It's very different to what was happening in Japan in 1950. Right? So we've seen this switch in pattern where the majority of deaths now are cardiovascular disease. That's not to say that infectious diseases isn't still important. It's not that we can stop focusing on infectious diseases and deal with cardiovascular disease. The challenge is, how do we accommodate both? Because many people are still dying from infectious diseases. This switch in disease pattern is also true if one looks at disability-adjusted life years. How many years of life are lost to either premature death or being disabled? And what you see is the top three are mental illness, and mental illness is there because it occurs early in life. So we lose, when somebody gets schizophrenia or depression or a mood disorder, they lose, we lose their contributions to a healthy life years over their entire life. Injury is the same. It tends to affect people at younger ages, and cardiovascular disease. So it's a very different pattern of disease and disability than we've seen, say, up till 20, 30 years ago. And it really reflects the fact that it reflects good things, the fact that we're reducing under 5 mortality and people are living longer. Now, just want to show this slide, which looks at life expectancy in the U.S. So by time. So it starts here at 1900 and goes up to the current time and then some projections. And so if you look at this is labeled EO, that's what demographers, that's their notation for expectation of life at birth, age 0. And what you see for both men and women is this increase in survival. This increase in survival here, before the antibiotic era, in the pre-antibiotic era, really reflects better public health measures, sanitation, better nutrition, less crowding, and better infection control. And then you can see that up until about this period, we had a rapid increase because we came from only in the U.S. in the 1940s, up until we're now at about 80, 81 in the U.S. I want to point this line out. This is the expectation of life at age 65. That is, if the population lives to age 65, what's their life expectancy? And you can see, as you would expect, it's higher, right? If you've lived to 65, it's higher than the population average, and now in the 80s in the U.S. This increase in survival is by and large due to better medical care. This is at an age when chronic diseases are established, people have diabetes, heart disease, and whatnot, and so the availability of high-quality medical services has driven this increase in life expectancy. So we see two things that drives life expectancy. What we talked about under 5 mortality, and that's really due to better nutrition, vaccines, and things like that. And then at older ages, high-functioning health systems. And I want to emphasize that primary care, strong primary care systems have been linked, and work with Dr. Liu Shi from our school and Barbara Starfield, have been linked to a greater life expectancy. So health systems that focus on a strong primary care component are associated with a longer life expectancy. Now I wanted to show this slide. This is an old picture from 1980 from a paper in the New England Journal, and it really changed the paradigm of how people think about disability at older ages. So this is a survival curve here, and by age, and this is what we saw in 1900, this gradual sloping downward of mortality, right? And primarily infectious disease mortality. This is where we were in 1980, right, where the curve is shifted to the right. And what Dr. Fries suggested is that we would see a rectangularization, making it a square, a squaring of the survival curve, where we would get to the point where people would live till they were 90 years old and then die. And so it would look like a square. And he pointed out that in 1980, we were 80% of the way there compared to 1900. And this changed our thinking about what are the patterns of mortality and disability. This is another slide that illustrates Fries's hypothesis. So this is, again, a survival curve with mortality here. And you can imagine a survival curve here, survival curve in the statistical sense, that there's, before you die, you get some diseases and the morbidity. And so there would be a survival curve for morbidity. And at some point between the time you get diseases and the time you die, you get disabled. And what Fries suggested was, what he hypothesized was, as the survival curve moved to the right and we lived to older and older ages, that the disability curve would shift to the right as well. So that we wouldn't be accumulating large portions of elderly people who were disabled, but in fact, we would see less disability at older ages. We might have increased numbers because of population growth, but we would see that there would be the salutary effect on disability just as there was on mortality. So the question is now, 30 years later, is that so? Well, there's a lot of data. You can imagine demographers and geriatricians and gerontologists look at this issue all the time. There's a lot of data, and it's mixed. But I think the preponderance of data suggests that Fries was right. So here's just one study. It's a very complicated slide. And what this shows is the percent of life expectancy spent in various states. And the state I want you to concentrate on is down here in the clear box, active life expectancy, no disability. No severe or moderate disability. And this is shown for both sexes, men and women. The patterns are the same, so let's just concentrate on both sexes. So over this 20-year time period, what appeared to happen is that, active life expectancy without disability, the percent of the life spent in that time went up in both men and women, and went up in a stepwise pattern. So, and in fact, in this study, the investigators could explain all of the increase in life expectancy by active life expectancy. So again, there's some mixed data, but most of the data, I think, supports that Fries was right, that as we do the things that we need to do to get people to live longer, they also are healthier than they were in previous times. Now, when we talk about life expectancy, one of the things that we have to talk about is place, where you live. Where you live determines your life expectancy to a large extent. And we could show that by country, but I want to show this data from Baltimore, where I live, in Baltimore City. There's 4 neighborhoods on this slide. The green here is Roland Park. That's a very high socioeconomic status neighborhood. That's where many Hopkins professors live. And then we have 3, but not me, I don't live. And then we have 3 poorer neighborhoods, right? Washington Village, Southwest Baltimore, and Holland's Market. So what do we see? So in the wealthy neighborhood, the average life expectancy is 83 years. Okay? That's equivalent to Sweden. That's higher than the US as a whole. It's higher than Maryland, the state in which Baltimore is, and much higher than the city of Baltimore. Look at these neighborhoods. The lowest one, the average life expectancy is 63 years. That neighborhood is 6 miles from this neighborhood, but there's a 20-year difference in lifespan. And that is equivalent to living in Bangladesh. Right? It's equivalent to the US in 1940. So within a very small geographic area, we have both Sweden and Bangladesh. And this is not unique to Baltimore. If we had the data to do this, we could show this in many communities around the world. So this reflects many things. It reflects level of education, income, access to healthcare resources, access to economic resources, environmental exposures, racial discrimination, a whole variety of things. But place matters. Now, so I want to turn from that sort of population dynamic public health view to a more clinical view. And I want to start by telling you about a study called the Precursor Study. So it was founded in 1946 by this woman, Carolyn Thomas, who graduated from the Hopkins School of Medicine. And one of the interesting facts about the Johns Hopkins School of Medicine is that from the very beginning they admitted women. They were required to admit women. And that's an interesting story. Why is that the case? And she was a graduate in 1925 or so, did her residency at Johns Hopkins, which was unusual, and came on the faculty in the School of Medicine. And then in 1946 founded this study called the Precursor Study. I was the director of this study from about 1988 or so until a few years ago. And what she conceived back in 1946 is that we needed a long-term prospective study that would identify predictors, or what she called precursors. The words risk factors hadn't been coined yet. She was interested in why some people got hypertension and why some people got coronary artery disease. And if you look at what she wrote, her hypothesis is that that the type of disease and whether you got it early versus late was really due to an interaction of genes, environment, and personality. She was way ahead of her time. There weren't good ways to measure these things back in 1946. But she tried, and she did a great job. She measured 6,000 variables at baseline in medical school in the students. And she enrolled classes in 1948 to 64 and did the history, physical, and psychological measurements, physiological measurements. Data collection took 4 years. It was spread out over the medical school. And then started in 1958 of following them up with questionnaires, thinking that they were medical students, former medical students. You could assess their health history by questionnaire. So, and then the annual follow-up also updated outcome data like mortality and disease. So at baseline, they were young. They were at graduation, average age 26. Their average cholesterol was desirable, 192. Their blood pressure, 115/69, also highly desirable. They were lean, but more than half smoked. And this is the kind of data that we could look at early on. This is cholesterol, serum cholesterol level in medical school, measured at an average age of about 24 years old. And then this is years of follow-up, so average age out here about 60, and looking at quartile cholesterol and showing that it predicted cardiovascular disease both early in life and later in life, in part because cholesterol tracks pretty well throughout the life. But what I want to focus on today is physical functioning. So we've measured physical functioning using a questionnaire called the SF-36, the Physical Functioning Score. And what we found is that if you look at their physical functioning, there's a very slow decline till about age 65, and then there's a more rapid decline, which is more significantly so than before 65. So two factors that we've looked at that are strong predictors of physical functioning after age 65. One is body mass index. So this is the same slide I showed you before, but now it's broken out by quintiles of body weight in average age 20 to 29, so 40 years before. And what you see is that the heaviest people here have a more rapid decline in physical functioning after 65 than the leaner people who were, and this again is from weight 40 years before. If we just look at the change in physical functioning, the decline after age 65, this is just what I showed you. Higher levels of BMI at age 29, more rapid decline in physical function. But it's true throughout the life course. So no matter when we assess weight in this group, it's a strong predictor of decline in physical functioning at older ages. The other factor that we've looked at is physical activity. So let me lead you through this. So for this analysis, what we did is we looked at physical activity at age 20 to 29, and then at age 40 to 49, and looked at change in physical functioning or difference after age 50. And what we see is, and compared this to people who were active both in youth and midlife. So if you were active in midlife, your physical functioning after age 65, I should say, is about the same as whether you were active at both times. So it was midlife physical activity that mattered. If you looked at people who exercised in youth only and stopped in midlife, they had a greater difference in physical functioning at older ages, right, than people who exercised at both times. But people who did not exercise at either time had a much greater reduction in physical functioning at older ages. And what this tells us is that physical activity is really important in terms of maintaining physical functioning at older ages, and it doesn't have to be lifelong, that even starting in midlife, you get a fairly big effect on maintaining physical functioning. So in summary, here's what I've said. So due to public health successes and improved medical care, society is getting older. And most deaths now are due to non-communicable diseases, but as Dr. Bloom is going to tell us, infectious diseases remain important. I haven't really talked about this except to talk about place, but the major determinants of health are social, right? So where you live, what you're exposed to, access to health care and resources, education, autonomy, that's what drives health. And in the U.S., we see these great disparities within our own city, and we have to address those. Because from a social justice point of view, but from a self-preservation point of view. Because people who see more than ever now, when I go around the world, these disparities are right smack in the middle of people's faces. Okay, so health systems that are strong in primary care lead to better outcomes at a lower cost. I didn't show you that data because my colleague Lei Shi is going to be talking about that at this meeting. And then the foundation for greater physical functioning at older age, for healthy aging, is really laid in youth and middle age. So thank you for your attention.
クラッグ先生、どうもありがとうございました。これで開会式を終了いたします。